Okay. Happy?
Yeah.
Cool. Thanks for downloading and welcome to Take Orally, the podcast from Dream Queen's Medical Centre at Nottingham. In this episode we'll be discussing The Child with a Rash Part 2. As ever, all information is correct at the time of recording. Any and all guidelines mentioned are correct for Nottingham University Hospitals NHS Trust. Other trust guidelines may vary. All views and opinions are the speaker's own. Hello, welcome back to Take Orally and The Child with a Rash Part 2. Delighted that Rachel Trix joins us again. Hello. Rachel.
Hello.
Welcome back.
Thank you.
And in Part 1 we looked at the non-blanching rash and we went through some viral rashes, had a bit of a chat about the importance of vaccination, etc, etc. A bit of a rant. And thanks for coming back just before you go on your skiing holiday.
That's right.
For us to have a chat now about bacterial rashes mostly.
Yeah. And some other causes. Rashes presenting with fever as well. So
cool.
Yeah.
So I believe you'd like to start with Scarlet Fever, is that right?
Yeah, so I sort of thought we'd talk about particularly children presenting with fever and a rash, again, sticking to the topic. And so covering some of the more common ones that we'll see. So certainly Scarlet Fever is common and potentially increasing in prevalence out there. It's caused by strep pyogenes, so a group A streptococcus, and is toxin mediated, and they often get this red pinpoint rash which spreads from the trunk and can settle in the flexures, the axilla, antecubital fossa. And what's really key about this one is they have a sandpapery texture to their skin, so you feel it and it feels like sandpaper.
Ooh.
And that first time you do it you go, that's what sandpaper rash feels like. Yes, now I know. They're often said to have a strawberry tongue as well, and some perioral pallor is sort of a textbook description as well.
Okay.
So that's something to be aware of. Scarlet fever in itself is generally very self-limiting. It's very mild, doesn't cause the child many problems. But the bigger worry is that it can, in a few cases, go on to sort of cause invasive streptococcal rashes conditions. So there's a risk of meningitis, pneumonia, septic arthritis, group A streptococcal sepsis. Which can be very severe, and we obviously don't want to miss. So it's important to identify and treat these kids, and these kids need a good period of 10 days of penicillin V ideally, to prevent the complications and also to prevent the spread, because they go from being very infectious to actually only infectious for about 24 hours if they've had their antibiotics. So.
And will they come in with them, is there a prodrome, like of a sore throat and things like that? Strep throat symptoms?
Yeah, so they'll often have a sore throat, they'll have a mild fever. It's not a particularly severe illness, but they might have sore red throat, and the rash is the main sort of factor that you find here. It has other complication factors, so things like rheumatic fever and streptococcal glomerulonephritis are important things. So even if you get these children presenting later, so such as your child with Coca-Cola urine and glomerulonephritis, actually asking back and saying, did they have these symptoms recently? Have they had this rash? Have they had fevers? Which can help point you down the line to the right diagnosis.
I'm right in thinking it used to be a lot more serious, as it was a major cause of child mortality 100 or so years ago.
Yeah, and with the advent of antibiotics, these things do improve. So hygiene and antibiotics and greater awareness. So certainly children who have come from overseas are far more likely to have had potentially rheumatic fever and problems such as that. So.
Cool.
Not to be forgotten.
I've only diagnosed streptococcal glomerulonephritis once, and I've never felt so much like house. Where as a young, I think he was a uni student, and he came in because he was peeing like dark brown, reddish, brownish.
Coca-Cola.
Exactly, urine. And he was like, oh my god. And he had an AKI, and AKI 1, I think it was. And I just said, how have you been over the last few days? And he was like, about a week ago I had a sore throat. And I was like, yes. And so, admitted him for some observation and checked his TTO, and they put him down as strep. And I was like, yes, I did something.
It's always worth sending off an ASOT in those situations, because then you can actually pinpoint it back to the original streptococcal infection.
Streptolysin.
Titer,
Cool. It's an antibody made against it. Okay, cool. There we go. Marvellous. Excellent. So that's our scarlet fever. So antibiotics, safety net. We worry about these conditions, but you can go home, live long and prosper, etc.
Yeah, exactly. Good 10-day course of penicillin. It is a notifiable disease. It's Public Health England, so these should ideally be all notified. And doing a throat swab in these cases is a good way to pick it up and get a definitive diagnosis before sending them home. Generally, don't wait and just put them on 10 days of antibiotics, even if you're not got the throat swabs, because then you're not faffing around with chasing people up and bringing them back.
Cool. So that's scarlet fever. What would you like to cover next?
I think on from scarlet fever, I think we always should mention invasive group A streptococcal infection. It is an acute life-threatening puerperal sepsis, and it often presents very similar to our septic shock child that we've talked about in previous episodes. So they will be shut down, they might have purpura, they'll look very unwell, and they can be sort of, not mistaken is the wrong word, because the initial management is very much the same as meningococcals, but it is something that is being seen quite frequently, particularly in this time of year. So the spring, as it gets warmer, we often see many cases, and it's always worth to consider sort of along with your early management, so your early antibiotics, early fluids, early PICU support, which we've talked about previously, is sort of adding in clindamycin into your antibiotics, because that's very effective in this situation.
Okay, and so they're going to be toxic. They're going to be very septic,
sick.
knocked off, sick-looking kid.
Yeah, these are your septic children. Prolonged capillary for time, lethargy.
They're not playing.
Hypotensive. Not
they're
playing.
not the one that's playing and runs in to see you. Yeah.
No, possibly even have purpura in places. So yeah.
Cool.
These are sick kids.
Sick kids.
Yeah.
Okay. So. Moving on from invasive group A strep.
So sticking to bacterial infections, we've got sort of staphylococcal infections, and these again, there's a really wide spread of different types of infections. So you can have your simple cellulitis, often children quite well with cellulitis, or abscesses, boils, localized infections, which don't cause them any systemic signs, but they're there. Often associated more with pain than fever. Yeah. And then you've got your impetigo, so that's your very superficial skin infections.
Goes through nursery groups,
lovely golden crusts, which are the honeycomb. Yeah. But perfect bacterial breeding grounds.
Incredibly contagious.
Yes. So they just need treating with either local or systemic antibiotics, depending on what the disease process is in that case. Good hygiene is really important in these cases.
Do you keep the child away whilst they've got the crust, or do they carry on normally? What's your practice if they've got impetigo?
So to remove the crust is really important. So actually just to clean them off, because that's where the bacteria is breeding. Yeah. And I would generally keep them away from nursery. I saw a really good something on Facebook the other day, which was sort of going through telling parents how long they had to keep their kids off school. And I think we should find it and talk about it, because that's quite useful, but I haven't got it here with me right now, worries. But we can find it in a bit. So that was quite useful. So you've got your sort of simple localized infections, but then again there's more severe infections. So staph scalded skin, which is another toxin-mediated infection, often in the under fives, those with immunosuppression as well, and they often do present very unwell. So they've got fever, they're irritable, and their skin is initially just sort of bright red, and you'll start to get some fluid-filled blisters appearing, and then the skin will just start coming off in sheets. And they almost look like a burn, and actually you manage them quite similarly to a burn in terms of sort of good fluid management, because they're potentially going to lose so much fluid through their skin. So they've lost that layer of epidermis. Almost, yeah. Cool. So good fluid management and using liquid paraffin, but to protect the skin. But the mainstay of that is that they should be looked after by burns nurses in similar places to this. They will also need IV antibiotics quite early and sort of strict fluid balances. And there's again a risk of secondary infection in these children because they've lost that protective skin barrier. So certainly something to be aware of and not to miss.
Yeah. Just looking at some pictures of it now, it really does look like burns.
Yeah.
I mean, for all the world, you'd say these kids had been scalded.
Yeah.
Hence the name.
Yeah.
It's a very well named condition.
Just you'd wonder why that scald pattern was around the mouth. They've got to look at a picture here where the infective signs are very much around the mouth and around the eyes. So, yeah, it does look like being scalded, but not with a typical scald pattern.
So that's scalded, esophagoccal scalded syndrome. What's next?
So, sticking to our fever and rash, I was going to talk more about a spectrum of diseases, although there's some debate as to now whether they are in the same spectrum or not. And working through sort of from Erythema Multiforme to Stevens-Johnson syndrome and toxic epidermal necrolysis, or TEN. And these are quite a range of sort of severity of rashes, and can be caused by viral illnesses, so maybe or bacterial, and also by drug, as a drug reaction as well. So the Erythema Multiforme we actually see quite commonly in paediatrics. And we see a lot of these children, and they'll come in with often a mild prodromal illness, because it's often caused by things like HSV, or it can be caused by mycoplasma. And they sort of get these red papules over their body, which then develop into sort of quite diagnostic target lesions. So you get the central dusky area, and then a pale zone, and then an outer ring of erythema, and they're quite classical of that. And they get the palms themselves are involved, and actually in most of these cases the rash looks far worse than the child is, and it's just important to reassure the parents, make sure that you're giving appropriate care. So antipyretics, making sure their fluids are okay, and most of these children can go home with effective safety netting. Obviously, if you think there is a drug as a cause, then that needs to be stopped and managed from there. Some of the drugs which can cause it are sort of non-steroidals, penicillins.
So erythema multiforme normally sorts itself out.
Yeah.
Do you give anything for them? No.
Sometimes they can have quite nasty mucosal involvement, and that's sort of at the more severe end of the erythema multiforme. So it's important about making sure, and this can be the eyes, the mouth, potentially even GI tract, but just making sure that appropriate care is applied to them and kids can eat and drink.
Cool.
It potentially progresses into sort of Stevens-Johnson syndrome.
Yeah.
And this is the more severe end of it, where they're also delayed type hypersensitivity reactions, but are mainly due to drugs, but can be due to mycoplasma and other viral infections, and they'll often sort of appear over the first few days if it's antibiotics, or even the first few months if it's something like an anti-epileptic which is causing it, and they will present with a prodromal flu-like illness. So again, symptoms of ERT, bit of fever, high temperature. They'll often have mucosal involvement of their eyes, so conjunctivitis, and then they sort of get this red rash and erythema multiforme, particularly involving the mucous membranes. So very much with the mouth involved, but also the genitals, the GI tract, the eyes, as we said earlier. And sort of depending on how severe it is whether they classify it as Stevens-Johnson or toxic epidermal necrolysis in the more severe end of cases. But here it's really important that you're managing not only the child itself, but also you've got all the issues that we talked about earlier. So fluid balances, risk of secondary infection because you've broken down the skin, making sure sort of eye involvement, that they've been seen by opticians, and making sure there's no sort of ulceration or uveitis there. They even have sort of, in the more severe end, GI risks of perforation and sepsis. So it's very rare, but it's certainly something to be aware of, and not to dismiss sort of all these early cases and just say, oh, it's fine. But good safety netting. The answer to all paediatrics is good safety netting.
Good safety netting.
Yeah.
I imagine if you're into Stephen Johnson's, or you've got even toxic epidermal necrolysis, that's a very specialist.
Yeah, and good early. It's not something that we will be managing in the ED. So,
no.
but it's something that we need to be aware of, and we sort of talked about the sick child and getting the right people down at the right time. And these people sort of need dermatology involvement quite early on, and fluids and supportive antibiotics if you're worried about it, and such on.
Cool. And next?
And then finally, so as the main final thing I want to talk about is the one which isn't an infection, but it can stump us all, and that is Kawasaki's, which we have sort of no known cause of, but is described often as an acute febrile illness with inflammation of the small and medium blood vessels. And this is just a correlation of symptoms, starting with sort of children who have a high fever for 5 days, and they have to have a high fever for 5 days. That's the diagnostic criteria. And then they also will often have mucosal involvement, so that red tongue, strawberry tongue, cracked lips. They'll often have conjunctivitis, which is non-suppurative. They'll get redness of their hands and feet, and possibly even desquamation of the fingertips. And they have lymphadenopathy, which is often unilateral as well. And these children are very irritable. The reason why we worry about it is, in most cases, it is a self-limiting illness and it gets better, but about 20% of children who are untreated will have coronary artery damage from the inflammation of the small and medium blood vessels. So they can get coronary artery aneurysms and potential
there was an alert from Archem about that, about a young person having coronary artery rupture, I think it was, and they traced it back to a childhood Kawasaki disease, and it was important to as a question to ask about.
So it's important to monitor those. You've got a good mnemonic there for...
Yes, crash and burn. I knew there was one, so I've looked it up. So have you heard this one?
No, I haven't heard that one.
So crash and burn. So crash, C-R-A-S-H, so C for conjunctivitis, R for your rash, A for adenopathy, S for your strawberry tongue, and H for hand, so swelling, erythema of the hands and feet, and then burn is your 5 days of fever.
So the burn bit is important. Without
you have burn and crash, maybe burn first, but yes. Important to think about. Cool, excellent.
But these children, again, it needs to be considered, and they need to be managed. And again, paediatric teams to get involved, and it's not something that we need to be managing acutely in the ED department, but it is something that we need to be referring on and making sure they're getting the appropriate management as early as possible, because you don't want to miss them.
Cool. And so it will usually get better within a few weeks?
Yeah, so often the children get better within sort of just over a week or so, but it's if they do develop the complications, then that's why they need treatment. So they get treated with immunoglobulin, and subsequently aspirin as well, to prevent any thrombosis which may occur as well.
Cool. So they will be admitted.
So they'll be
admitted for that.
Yeah.
Okay. And how are they in themselves? So they've got a fever, so probably not feeling great.
They are miserable.
Yeah.
These kids are your miserable kids. Often, and actually going back to one of the things that can be confused with is potentially measles. Because they present with a very similar rash, high fevers, miserable looking, conjunctivitis as well. So it's certainly something to be aware of in your differential diagnosis.
We found this infographic eventually through quite a bit of searching. It is from Cheshire, but they say it's based on the Public Health Agency guide, basically about different conditions. So when should my child return to school? Chickenpox, when all spots are crusted over, conjunctivitis. None, does that say?
Yeah, so it says they don't actually need time off for conjunctivitis.
Okay, diarrhea and vomiting when they're 48 hours free, glandular fever is okay, hand, foot and mouth okay, impetigo. When lesions have healed all 48 hours after commencing antibiotics.
Yeah.
Okay, cool. So yeah, we'll put that up on the blog entry and we'll push that across social media as well. So.
It's good for parental information when they ask you, can I send my kid back to school tomorrow? And you just need something up your sleeve to go, don't know.
Excellent. Thank you very much, Rachel.
No, that's fine.
Anything else you wanted to say?
I just wanted to say, remember that rashes can not only be presenting with illness, but they can be signs of underlying problems. So lots of rheumatological problems present with rashes. So yeah, if you're ever worried, then don't be afraid to seek advice. Certainly here in Nottingham we have a really good dermatology service for the paediatric team, so if you're ever concerned and you want a patient seen by a paediatric dermatologist, or even some of the paediatricians are very good at dermatology here, you can always refer to the paediatric dermatology team, and they will often see them in a few days if you're worried about how severe things are. So yeah, don't be afraid is what I'd say.
Don't be afraid.
Don't be afraid.
Excellent. Thank you very much, Rachel. Enjoy the skiing.
Thank you.
Don't injure yourself.
I'll try not to.
And moderation on the après ski. And yeah, hopefully see you again very soon.
Yeah, see you soon.
Thank you very much, everyone. Bye bye.
No, thank you.
That was the Take Orally Child with the Rash episode 2. Remember, you can find the blog entry for this podcast at takeorally.com. This podcast will be available across Apple Podcasts, Spotify and SoundCloud. You can find the take visually for this podcast at both the blog and on Instagram. Remember to follow Take Orally on Facebook and Twitter. And remember, for more information about research and education opportunities within emergency medicine, acute medicine and major trauma, NUH Dream can be found on both Facebook and Twitter.